online. And that's not such a bad thing. Dr. Ryan Ford is our speaker tonight. He's been good enough to come down. He is Assistant Professor of Medicine, Director of Viral Hepatitis and Emory Transplant Center. Best I can tell by looking into his background, he was born in Emory and never left. Medical school, residency, fellowship, professorship, he's the Emory. And we're glad to have him.
Thank you. Appreciate it.
Thanks.
I like how you could watch this at home with a glass of wine, so I appreciate you all being here. And if there is wine, that's fine with me. Thanks for having me down here. I'm a transplant hepatologist, but I have spent all of my training from medical school and beyond at Emory, and I did my undergraduate at University of Georgia. I actually grew up in Gwinnett County, sort of the suburbs of Atlanta. So, and one of my mentors was James Spivey, who many of you probably know because I know he lived down here, and he helped build the liver transplant program at Emory and helped recruit us to where we are today. And we were sad to see him move to Arizona this last year. If you didn't know that, he's out there building a new residency program, so he never stopped building. But thanks and some of you I've seen before, and happy to talk with any of you afterwards. We see a lot of patients from the Clark Holder Clinic in the LaGrange area, so hopefully we're servicing you all well. So we're going to tackle a really fascinating topic, especially in today's current era of having actually a cure for hepatitis C. Many of you have probably trained for years where hepatitis C was one of those things someone had, but the treatments made them sick. They hardly ever worked. And I think now it's something that is getting a lot more attention because not only can we cure it, but we can actually change outcomes. So hopefully I'll go through a lot of slides, and at the end you'll be a master of this. I have served on advisory boards for Gilead. So those are my disclosures. So this is just our outline, and I started with just sort of 5 cases that we'll run through, and then we can kind of come back to them at the end. But I kind of was thoughtful in what I put in each case. So case 1 is a 62-year-old baby boomer, African-American male, who came to his primary care doctor for an annual physical. No complaints, past medical history, hypertension, depression, and GERD, and his meds include hydrochlorothiazide, St. John's wort, which I put in here, and we'll get back to that, but I now have a new mission to just make sure this disappears. It seems to interact with every drug that's ever comes to the FDA, so maybe if you have patients on this, always be wary. And then omeprazole, which we'll talk about its implications with hepatitis C treatment. Physical exam is normal. Lab testing is basically normal. And because he's a baby boomer, you all checked one time to see if he's been exposed to hepatitis C, and the antibody test was positive. So this is just kind of a standard baby boomer screening. And now what do you do? So we can make this a little interactive. It's the next step with the positive antibody. There's no one answer.
Viral load?
Perfect. All right, so if you're able to, it actually is very helpful to go ahead and check a PCR viral load, because that will confirm if they actually have chronic infection. You will find some baby boomers that have a positive antibody that have a negative viral load. They actually were lucky enough to have been exposed to the virus, but to have gotten rid of it. So if you can check a viral load, that's going to save a step. We will have occasionally patients that come to clinic who have a positive antibody, and they've driven all the way, waited 2 months to get an appointment. They're nervous, and I do a viral load and it's negative. That's the best phone call I can ever make. But if you're able to send that, if not, we're happy to do it as well, or consult over the phone. So good. And then what we might do with a positive viral load is we also then want to assess, do they have advanced fibrosis? What degree of scarring might they have? Maybe they have no sequela of chronic hep C. And then, of course, we could talk about treatment. So case number 2 is a 67-year-old Caucasian female with elevated liver enzymes. And so that prompts testing, where she is found to have hepatitis C antibody positive. And she also has a positive hepatitis B core antibody that's positive. Her surface antigen for hep B is negative, and she does not really have demonstrated immunity to hep B. So she may have been exposed to hep B and C during the same time. So a confirmatory PCR is positive with a viral load of 3 million international units per ml. And her liver ultrasound is normal. So what next? So we don't think we have cirrhosis. We do have chronic hepatitis C, and there may have been prior exposure to hep B. So probably unless you're treating yourself, you'll want to refer her for treatment. of hepatitis C. The reason I put this in is because we have to pay attention to the fact that she's been exposed to hepatitis B as well. Because as we treat her hepatitis C and hopefully cure her, there are cases of hepatitis. You also should check them for exposure to hepatitis B, and it's also a good idea to see if they're immune to hepatitis A. Obviously, if they have risk factors with IV drugs, things like that, an HIV test would also be useful. Case 3, 58-year-old Caucasian male with a history of hepatitis C cirrhosis, presents with jaundice, ascites, and hepatic encephalopathy. His MELD score, if you know what that is 32, which is high. And should he be treated for hepatitis C? Yes or no, and what is the best next step? So basically, a MELD score of 32 is extremely high, so he's very sick. And so normally we're not going to treat his hepatitis C in this setting until things are stabilized or until after we've transplanted the patient. So the best next step really in patients like this is to be referred to a transplant center. If he's a transplant candidate, then he's going to benefit from a transplant first, and we can treat the hepatitis C after. Case 4, 62-year-old African-American female is found to have hepatitis C genotype 2 that was likely contracted from a blood transfusion in the remote past during a hysterectomy. That's a very common scenario for genotype 2. A FibroScan is consistent with advanced fibrosis. We'll get into what that is if you don't know what it is. An ultrasound is negative for cancer. Her platelet count is borderline low. She's treated for her hepatitis C and cured. So does she require any further follow-up from a liver standpoint? So she has hepatitis C genotype 2 and we cured it. There is suggestion of advanced scarring here. There's no cancer and her platelet count is borderline low, which tells you she probably was on the cusp of cirrhosis or early cirrhosis. So the take-home point here is that she does require follow-up because these patients still could develop cancer. And I think this is one of the things that scares me the most as a hepatologist is now we have these, let's call it easy cures of hepatitis C, but what are we going to do with the people that are cured and just kind of disappear? We need to make sure they follow up. Otherwise, they're going to come back several years later with an unresectable cancer. And finally, a 23-year-old male who uses IV heroin is found to have both hepatitis C and HIV infection. He is entering into a methadone program for his heroin addiction. Ultrasound is negative for cirrhosis or cancer. He is started on antiretrovirals for his HIV by his local ID clinic. What should be done about his hepatitis C? So the answer here, as this is becoming a more common scenario with the upsurge of IV drug use in this country, is yes, he can be treated, not only to help himself, but also to help prevent new transmission. You do want to take care of HIV first to make sure that's stabilized, which is why I put that in there. And methadone is not a contraindication. Active IV drug use is technically not a contraindication. You probably want to just make sure that they're actually going to take the medicines, though. Otherwise, that probably is a waste of time. So that's kind of a semi-controversial, but a real scenario. Okay, so hepatitis C was discovered in 1989, so it's relatively new since we discovered it. And that's why a lot of people got it in the 70s and 80s. We didn't even know about it. And remember, if patients actually got sick from it, they were told they had non-A, non-B hepatitis. It's a single-stranded RNA virus. There are 6 major genotypes. It's primarily transmitted through blood. And the incubation period is variable. Now, unlike hepatitis A or other infections, is you often don't get sick from this. So it's rare that someone comes and they're yellow and sick and you test them and they have acute hepatitis C. We do see it, but it's just not as common. The hepatitis C virus encodes an RNA-dependent RNA polymerase that lacks a proofreading function. It has a very high viral turnover and a very high mutational rate. And so that has been problematic in trying to characterize and cure this virus in the past. It replicates rapidly, that's why you have viral loads in the millions, and there's multiple quasi-species. This is the hepatitis C virus as compared to hepatitis B. Hepatitis B is a double-stranded DNA virus. This is a single-stranded RNA virus. And if you look at the RNA transcript here, this will be important as science has advanced, and these are now the targets that we have called direct-acting antiviral agents. So this is why we can use the word cure. You may have remembered interferon and ribavirin. Interferon and ribavirin did nothing specific to this virus, but the new agents actually target specific proteins that are made through this virus, and that's why we can eradicate it. This is the life cycle. This is a hepatocyte, so the virus binds. Endocytosis occurs, it uncoats, and then the RNA starts to be translated into proteins. You get a vicious cycle, and then you release millions of virions in the bloodstream. So again, previous treatments, ribavirin and interferon, they really acted on the immune response to this virus. So this is where interferon pretty much worked in the life cycle. But now we have agents that actually act specifically on the virus at different phases of replication and release. Worldwide, there's approximately 180 million people with chronic hepatitis C. And just to point out, hepatitis B is a larger problem than hepatitis C, where there's northward of 400 million people with hepatitis B in the world. Nevertheless, there's a lot of people. And if you look here, the prevalence of infection in blue, which is the United States, ranges in the general population from 1 to 5%. And that's true of most developed nations. In the United States, approximately 3.2 million people have chronic hep C infection. So that's a prevalence rate of between 1 and 2%. However, it's recognized that the real number is probably higher, 5 to 7 million, because we really don't account for homeless people, people who are incarcerated, and as you can imagine, there's a pretty high prevalence rate of hepatitis C in those populations. So it was noted that this is your general population prevalence of 1.3%, but if you're a baby boomer, it's almost triple. If you're non-Hispanic Black, it's about double, and males have a higher risk of chronic infection than females. Females are more likely to get rid of the infection on initial exposure. That may have to do with endogenous interferons as well. The most common genotype in the United States is genotype 1, so it's over 3/4, and that's divided between 1A and 1B. Then you have some genotype 2, a little bit of genotype 3, and it's pretty rare that you're going to see 4, 5, or 6. You might see 4 in anyone who's from Egypt, and 5 and 6 are extremely rare. So if you've seen 1, you probably haven't seen more than that. So there's many modes of transmission for this virus. The most common is IV drug use. And again, it's really scary because we're seeing an upsurge of that in this country. Also, having received any blood transfusions or products before 1992, needle stick injuries in healthcare settings, and then if you're born to a hep C positive mother. Now, less common, and these are common questions for patients, is, well, maybe they got it through sexual exposure. It is possible, but it's low efficiency. And again, you have to kind of remember it's blood-borne, so perhaps different sexual practices that may or may not involve blood or bleeding would increase your risk. And then there's things that are hard to test, like did anyone ever share a toothbrush or razor? I always wonder about some of these spas, nail spas, and barbershops. And, is there a possible transmission there? It'd be hard to test, but if there's minute cuts and bleeding, it's possible. And then you also have other potential like healthcare exposures. So if you are exposed to hepatitis C, the likelihood that you're going to have chronic infection is about 80 to 85%. Again, women are more likely to clear it, but it's still, most people are going to end up with chronic infection. And this just shows, again, that IV drug use, here's your general population with a 1.6% prevalence. Well, if you use IV drugs, it's through the roof. Your risk is super high. HIV co-infection, usually because you have common risk factors. Blood transfusions before 1992. Dialysis patients have an 8% prevalence rate. And then the more sexual partners you have, the more it kind of is a dose effect. So perhaps that also indicates other behaviors that might put you at risk. People who inject drugs, again, this is the #1 reason for new infections in the United States today. And it's kind of scary if you look at the prevalence of hep C positivity, antibody positivity in persons with either a current or past history of drug use. This is any drug use. It doesn't have to be IV drugs. It's almost 1 out of 3. So anyone that's ever used drugs, 1 out of 3 may have hepatitis C antibody positivity. Now, if it's IV drugs, it's 2 out of 3. So it's quite remarkable. And again, that's the majority of new infections today. And also, a lot of these young people who are now using IV drugs, they also have a history usually of oral opioid prescription drug abuse. We just had an internal medicine grand rounds at Emory on the epidemic of opioid abuse and dependence, and it was pretty scary. And there was a gentleman who works with the Drug Enforcement Agency and talked about how the Southeast is actually probably more, there's more drug trafficking than, say, New York and Miami. So this area as well. So if you look at IV drugs, that's a bigger risk, but even just non-IV drugs and even marijuana only. So those are things in histories that might prompt you to test. We talked about incarcerated or homeless people, and also the problem here is there's also a lot of unregulated tattoos done in prison, also on the streets. And the jails, there are some jails that will test and will also treat hepatitis C, but many of them don't perform routine screening, and a lot of times if an inmate's only there for a short period of time, they won't bother. If you look at the major cities in this country, now the total number of people, just gross number of people with hepatitis C is listed here, with number 1 being New York City, number 2 LA, but notice Atlanta's 10. So it's in the top 10 in terms of total number. If you want to look at the highest actual rate in any city that's over 1 million people, then you have these cities here. And notice Jacksonville, Birmingham, Memphis, New Orleans. And this graph shows that the baby boomers, as we mentioned, account for 3 out of every 4 people that have hepatitis C. And so this was the data that prompted the recommendation that all baby boomers be tested at least one time. Because if 3 out of 4 of everyone in this country with it have it, and we know we were missing a lot of people, we weren't doing very good at risk factor-based screening. I mean, it's difficult, right? There's so many things to do in clinic. You may not always have accurate information, and you have limited time. So the one-time baby boomer screening was based on this. 3 out of 4, and baby boomers are anyone born between 1945 and 1965. Now, if you, with pregnancy, if a mother is hepatitis C positive, there's a 4 to 10% risk of passing this on to the baby. Why is this not higher? Well, because the mother also has circulating antibody. So the antibody crosses the placenta and technically protects a lot of babies. However, sometimes it's not as perfect, and so there's more risk of passing this on. Also, if you do have a needle stick, it's fairly inefficient when the transmission. So if you get stuck by someone who's hepatitis C positive, you don't have to freak out too much. You know, certainly we got to go through the testing, but you're more likely to get hepatitis B if you're not vaccinated against that. So this is 10 times lower risk than hepatitis B infection. And so the higher the viral load in the patient, the bigger the exposure. If you're not wearing gloves, if it's a large needle, that will increase your risk. But if you look at the overall prevalence of healthcare workers, it's still about the same as the general population. So just working in healthcare technically doesn't make you higher risk, but be careful with needles. And if you did get stuck and you happen to get it, at least now it's sort of the thing where we have a cure, so it's not quite as scary. If you do have chronic hepatitis C infection, which is about 80% of people that are exposed, then what we worry about is over 25 to 30 years, in the absence of any other insult, you can develop, about 20% of people will develop cirrhosis. Once you have cirrhosis, there's a real risk of cancer, hepatocellular carcinoma, decompensation, and death. So being a transplant hepatologist, this is pretty much where I live. And then in my general hepatology clinic, I'll see some folks here, but this is what's really dominating the landscape in transplantation right now. And this is just another way to show you may have chronic hepatitis C in normal liver, but over time it can progress to cirrhosis. And once you really start to progress, you're either going to need a liver transplant or you have a risk of dying. And remember, if you get hepatocellular carcinoma, many patients can be transplanted and cured from this too. So hepatocellular carcinoma is another rising reason for transplant. This is just grossly showing a normal liver. Once you start to develop more fibrosis and cirrhosis, and this is what liver cancer looks like grossly. That's a large tumor. So based on the current epidemiology, it's estimated that we have yet to peak the number of baby boomers, et cetera, with cirrhosis, which is alarming because I'm pretty sure you're all seeing just as many patients with cirrhosis hit the emergency room in the hospitals and maybe your clinics, and yet technically we haven't peaked yet. 2020 is where about 1 million people should have cirrhosis. Now we think that we've already peaked the number of people with hepatitis C. However, be looking for, again, a rise of that because of IV drugs. But this is what we need to be on the lookout for, and this is what we're trying to prevent and hopefully reduce. And this is just another way of showing that in 2020, we should see the peak of decompensated cirrhosis and also liver cancer, which has been the most rapid rising cancer in the United States in the last several years. Hepatitis C is still the #1 reason for liver transplant in this country and for patients being on the transplant waiting list. Notice alcohol is number 2 and likely will always be number 2. And then I mentioned liver cancer. Now, liver cancer is usually due to cirrhosis, and it's highly linked to both Hep C and alcohol. So really, a lot of these cases also have hepatitis C or alcohol. Cholestatic diseases, PBC, PSC, acute liver failure from Tylenol and medications and things is very rare. It's an emergency, but it's rare. And then any ideas what might sit right in here as a cause of cirrhosis in this country? In LaGrange especially? Fatty liver. Yeah. So this will actually become number 1 very, very soon. It's rapidly rising. Now there are other problems that hepatitis C can cause besides liver disease, and you probably have seen some of these in your career. You can have mixed cryoglobulinemia and vasculitis. It is associated with Sjogren's syndrome. Certainly non-Hodgkin's lymphoma, B-cell lymphoma is highly correlated. Porphyria cutanea tarda, and then also MPG and renal failure. Now there's possible associations with diabetes, joint pains. Certainly I've seen autoimmune thrombocytopenia. So that this always fools you because you see a patient with low platelets and Hep C and you assume it's cirrhosis. But sometimes it's not, it's actually autoimmune thrombocytopenia. And it can be linked to thyroid disease and corneal ulcers, etc. This is one area that became very important when insurance companies wouldn't pay for patients' hepatitis C treatment if they didn't have cirrhosis, because when the drugs first came out, insurance companies said, well, if you don't have cirrhosis, we're not paying for it. And so we would always have to fight and say, well, if they develop lymphoma, that's on you. If they develop kidney failure, that's on you. And we would usually win. But this was helpful for that. The impact of hepatitis C on health-related quality of life. I mean, this is absolutely true. Patients that have chronic Hep C for years and years before there was a cure, you know, a lot of times they would keep it from family members, but their overall general health and well-being was diminished compared to controls. And what's nice is this has also been shown to improve once you cure them. What's scary is chronic hepatitis C really affects more people in this country than breast cancer, prostate cancer. It dwarfs HIV. And really, hepatitis C did not get nearly as much attention in research dollars as HIV did when it came out. Heart failure is still high, and remember, you could almost move this up to 5 million if you include homeless and incarcerated. And in 2007, hepatitis C surpassed HIV as a cause of death. So it's extremely important. Now, those graphs that I showed you that said if you have chronic hepatitis C, over 25, 30 years, you might develop cirrhosis. So that's why we're seeing it now in baby boomers. That's in the absence of other risk factors of liver disease. So if you also drink alcohol and you also are obese with diabetes and you're a male, everything's going to be accelerated. If you happen to have HIV on top of it, everything's accelerated. So this is why you may see patients that have had Hep C for 15 years and they already have full-blown cirrhosis. So you can really, the liver, multiple different risk factors for fibrosis can make it move towards cirrhosis much more quickly. Now, why is hepatitis C curable? And why is hepatitis B and HIV not curable? It has to do with the virus itself. The fact that this virus does not enter the nucleus. It's just an RNA virus that just enters the cytoplasm, means if you can kill all of these cells that harbor the virus, you're done. Whereas hepatitis B has this covalently closed circular DNA that incorporates into the host DNA, and HIV also has proviral DNA that incorporates into the DNA. It's really hard to get rid of it completely because it can archive in the host genome. And so that's why these two diseases are treated with long-term suppression. And we have great drugs to keep the blood undetectable, but we can't rid the body of it until we can get better science to clear all the cells nucleus. But this is why hepatitis C is, in fact, curable. So this is data from 2013. So I point that out because I think we're changing this. But we talked about 3 to 5 million people with the virus. About half of people know they have it, whether it was a blood test checked years ago, and sometimes blood tests were checked years ago, and people already forgot about it, and it's sitting there on the chart because there was no treatment or good treatment at that time. And only about 1/3 of these patients were ever referred to care because of the futility of it. And only a minority of these patients were ever treated. So it was estimated that just about 4 years ago, only about 10% of people had been treated. And just if you have trouble remembering that, just if you ever worked at the VA, it was basically every single patient that had Hep C, there was some reason not to treat them. Because with interferon, it was, oh, history of depression, check. Anemia, check. You know, renal failure, check, so no one could be treated. Now, some people were more aggressive than others, but times have changed, so we're hoping to completely change this photo. Now, what is cure? When I talk about a cure, well, a cure is what's called a sustained viral response 12 weeks after you complete treatment. It used to be 24. We used to have to wait 6 months. But it's been shown that if you do not have virus in your bloodstream 3 months after treatment, you're cured. So when we treat people, say we complete treatment this month, I tell them come back around the new year, around Christmas, and if it's not there, that's the best Christmas gift you'll have. It's cured. So the 3-month check after treatment is vital. And once you have that SVR12, it's equivalent to a cure. And so we're able to use that terminology interchangeably. Now, why cure people? Well, hepatitis C viremia has been associated with increased mortality. Now, this is a Taiwanese cohort study. So patients that had viremia had a higher all-cause mortality, liver cancer, and extrahepatic diseases compared to those that did not have viremia, that were previously exposed, and those that had never been exposed. So there's clear damage associated with viremia. And if you ever remember this paper in JAMA by Vandermeer, this basically showed that if you can achieve an SVR or a cure in patients that had advanced fibrosis, that you actually improve all-cause mortality. So this was a landmark paper in 2012. And this is showing here that without a cure, this is your cumulative incidence of liver cancer, liver-related mortality or liver transplant, and all-cause mortality. And if you cured people, you dramatically changed their outlook. So this really was one reason why insurance companies had to treat people that had advanced fibrosis. So the ones that they didn't want to treat were the ones that didn't have advanced fibrosis because in theory there wasn't proof that you were changing their outcome. Treatment may reduce hepatocellular carcinoma risk, and this is just a meta-analysis, and it basically tends to favor cure. And you might even see regression of cirrhosis. I think we need more data on this. These are just kind of early studies. We definitely know that hepatitis B fibrosis can basically regress with long-term antiviral therapy. We suspect that we can reverse cirrhosis, that being with hepatitis C cure. That being said, we just have to be careful because patients are real quick to say, oh great, I'm cured of everything. But remember, some people have really advanced cirrhosis with portal hypertension. And although you will see some improvement, it still doesn't go away completely, and there's still risk of cancer. And so this is what we need to work on, and it's one thing that I think we all together in this room can work on is the science is there. There may not be any more medications that come out. There's been a lot that have come out in the last 4 years. And so now it's going back to grassroots. Let's find these people and get them into care. And I would actually say that it doesn't have to always be referred to a hepatologist or an IV clinic. I think that these drugs, if people are interested enough, can easily be taught to primary care doctors, to gastroenterologists, if anyone's interested. They're actually not that complicated. Now, I think they used to be and people were scared, but if that's the best way to get people linked to care rather than wait for an appointment, if there's not enough specialists, then we can make a difference on the primary care level. And if you see sort of the timeline here, especially regarding the baby boomer one-time Hep C screening, it just recently that the CMS, finally, I guess, agreed based on all these recommendations to cover a one-time screening hepatitis C antibody for baby boomers. Now, how do you do it? Well, the hepatitis C antibody test is an ELISA test, so it's just a simple blood test you can send. Some laboratories, if it's positive, if the antibody is positive, will go ahead and do a reflex viral load, but again, many don't. So if you have a hepatitis C antibody positive, it'd be nice if you want to go ahead and confirm it with an RNA viral load. But if you're not sure and you want to send, refer them, that's also, again, very easy. So if they do not have RNA, then they actually do not have the chronic virus. They were exposed to it, but they got rid of it. The only caveat of when you don't want to check a hepatitis C antibody as your initial screening test is if someone's immunocompromised. So if they're HIV, if they're on dialysis, you might want to just check an RNA just right out of the gates because you could have a false negative antibody test. But otherwise, it's a very good test, and this is basically, there's ways, and the blood test is simple, but they're even trying to get better where you can swab a mouth, and you might be able to really rapidly screen people at fairs, and that's coming, I think, soon. It may not have the exact same sensitivity and specificity, but that may be a start. And this is just the ELISA test that has a sensitivity of 97 to 100%. And false negatives may occur, again, in dialysis patients, HIV-positive patients, or immunosuppressed patients, so keep that in mind. Now, how do you assess for liver fibrosis? So hepatitis C, identifying if it's there is fairly easy if you think about it in order to test. So then what my job is when I see anyone with hepatitis C, and again, you can go ahead and jump ahead on this, is, well, do they already have cirrhosis? Are they lucky? They've had it for 30, 40 years and there's no damage? Well, sometimes the physical exam is obvious, right? So if someone has portal hypertension, and again, if you are able to detect splenomegaly, caput medusa, portal hypertension, spider angiomas, all the things in Harrison's textbook that might point out cirrhosis. But sometimes patients look totally fine and you don't know. And so lab testing might tip you off. So you might see a low platelet count. That's one of the most common lab abnormalities in patients with cirrhosis is thrombocytopenia. Can't tell you how many patients I see that first have been routed through hematology. They've already gotten their bone marrow biopsy, and then an ultrasound occurred and they had cirrhosis. Super common. Imaging, other lab testing things to look for would be, again, bilirubin being elevated, direct bilirubin especially. Albumin might be a little bit low, and then elevated liver enzymes sometimes can be a tip-off. So imaging, if someone's thin, an ultrasound is going to be fine. A lot of times people aren't very thin, so a CT scan or MRI might be a better way to look at the liver and spleen. Many patients are diagnosed with cirrhosis because they get a scan for some other reason. I see that so often. They got in a car accident, they got scanned, they took care of their leg fracture, but the ER said, by the way, your liver looks a little bumpy, and then they go down the pathway and they find out they have Hep C. Liver biopsy is done in some cases. We're getting away from this because patients just want less invasive modalities, and we'll go over that. So there's things like elastography or FibroScan, which I have a slide on. And then I actually see a lot of patients that surgeons refer us them because they take out their gallbladder or they're doing a surgery and they notice the liver looks funny. So they'll either take an intraoperative biopsy or they'll just send them our way. And so that's another common. So patients with compensated cirrhosis don't know they have it. It's only the decompensated ones that are obvious. So when we look at liver biopsies, you'll see stage 1, 2, 3, and 4. And that's what this is. Stage 1 is a little bit of scarring around the portal triad. You start to see a little bit more scarring with maybe a little bridging here, and this is stage 2. Once you start to have focal bridging, and you're almost forming nodules, this is stage 3, and this is clear-cut cirrhosis with nodule formation. And this is where you start to get impedance of blood flow and portal hypertension. And grossly showing you that blue is scar tissue here. This stains collagen on the trichrome, and red is the healthy cells. So there's stage 1. That's stage 3, bridging fibrosis, and there's clear cirrhosis, and you even see some steatosis here. So this is, if you do biopsies and you ever hear stage 4, it freaks patients out, but it just means cirrhosis. But they equate that with cancer. So stage 4 cancer, I'm going to be dead in 2 months. Stage 4 is the pathological description of how much scarring's there, and I just tell them, don't even say stage 4, just say cirrhosis. Because then, then we talk about compensated cirrhosis, decompensated cirrhosis. Now I like this slide because this is why liver biopsy is not perfect either. So if you take a biopsy from the same patient, and this is clearly cirrhosis. If you take it here, you're going to say, oh yeah, that's cirrhosis, no problem, because that's what a needle does. It just goes in and takes one little core. If you were to look at this sample, you would call it stage 2. And so there is definitely sampling error that can occur in liver biopsies. So every now and then you'll see someone that had a biopsy, they'll say stage 2, but you're looking at them, they have ascites, their platelets are low, their spleen's big. Forget the biopsy, they actually they have cirrhosis. Now, transient elastography is an ultrasound-based technology that also measures the stiffness of the liver. And we have, this may not be available everywhere. At Emory, the radiology department does this part. What I like about this is you get to screen for cancer because you look at the liver as well, and you get a measurement of how stiff the liver is. The stiffer the liver, the more likely there's cirrhosis. The softer the liver, the more likely that there's not scarring. So what's nice about this is you can screen for cancer and get a measurement of stiffness. Now the FibroScan is something that we have in our office. So the radiologists don't do this, but we do. The nurses can be trained to do it, and it takes about 10 minutes. Patient lays here, you put this probe up in between their rib space, and it's the same technology of shear wave, where it measures the stiffness of the liver. And then you get a report that looks like this, and this is the median kilopascals or median stiffness. So based on the disease process, it's, if you have greater than 12 kilopascals, then that's consistent with possible cirrhosis in Hep C. If it's less than 7, then you feel pretty good. Patients should be fasting for this, and there are a couple of things that could cause a false positive or elevation if there's a lot of inflammation or hepatic congestion, for example. The FibroScan machine costs about $130,000. So it's, again, if you do it, you get reimbursed probably about $120. So you'd have to do a lot of them to kind of make it, but again, this was something that we were able to kind of get because a lot of insurance companies demanded that you have this in order to get treatment approved. So something to keep in mind. Now, most of the patients, if you just looked across the United States and we identified everyone with hepatitis C, most of them are going to be F2 and more. So you will see some that have no scarring, but the majority of patients are going to fall F2 or higher. All right, is that fairly clear so far? Because now we're going to jump into the revolution, which has been treatment. We haven't been able to talk about this for years. So I call it a revolution because it really is, and it's just been an explosion since the first acting antiviral agent became available. There's other revolutions, but this one is bigger. So 2001 to 2011, all we had was pegylated interferon, which was once a week interferon, and ribavirin. And I already talked to you about how none of this was specific for hepatitis C. This was just immune modulation and trying to boost your own immune system to get rid of the virus. You would make people sick, sometimes up to a year, maybe longer in some cases, and the chance of cure was a coin toss in genotype 1 patients. You could get higher cure rates if there was no cirrhosis in patients with genotype 2 or 3, but again, the majority of patients were 1. And this was it was all we had, and so there were people that were cured, and you'll see people now that were cured, but it was a horrible story. I mean, their side effects were awful. But once we had direct-acting antiviral agents, and the first ones became available in 2011, it's changed treatment altogether. And we now are in a non-interferon treatment era. So if you look at, I showed you before the RNA and then the proteins that are translated with the hepatitis C. Well, the targets that you'll see, the class of drugs that we look at now are the NS3 and the 4A inhibitors. I like to call those the protease inhibitors. And then you have the NS5A inhibitors. And then you have the NS5B inhibitors, or the polymerase inhibitors. So those are the 3 classes of drugs that are currently available. There, and there. And if you recall HIV, you don't usually treat patients with HIV with one drug. You want to hit multiple mechanisms of action to overcome any resistant variants. And so the current algorithm is that you're going to combine multiple targets. Sometimes you'll have 2 drugs in one pill that you might take. But by combining these targets, you can achieve nearly 100% cure rate the first time around. And that will basically suppress and cure all the different variants that come from that sloppy RNA polymerase, and will also prevent the emergence of any new mutations. So the evolution of HCV therapy went from, this was the original mono interferon before it became pegylated, where they had to do it 3 times a week injections. It was once a week injection with a cure rate of 50%. And then in 2011, when the very first protease inhibitors came out, they had to be used in addition to ribavirin and interferon. So we took what was already hard, added a new agent, and made it even harder, but we were able to gain about 20% more cure rates. But it was really awful. Patients had to eat with telaprevir, when it was the first DAA out, boceprevir and telaprevir. You had to eat 20 grams of fat before you would dose it, and then you had to dose it 3 times a day. The 20 grams of fat, everyone's like, well, what's that? And you had a list of foods, bagel with a lot of cream cheese on it, peanut butter, cookies, a bag of chips, and people were just starving it down despite vomiting because they were sick and nauseated. It was like they were stuffing fat in and then taking the pill. And then as the pill would go through, it would cause anorectal burning. This is not a joke. It was awful. But patients were desperate, and they went through this, and the cure rates were almost 80%. So that was awesome. But thank goodness we continued to advance, and the medical scientists continued to develop new cures to where We now have many regimens or one pill once a day, and the cure rate is 98% or higher, oftentimes 100%. And if that doesn't work, there is actually a salvage regimen available as well. So it has been an explosion from 2011 to now, and that's why I call it a revolution. And it's exciting because now all these people that have had decreased quality of life, they're at risk for liver disease and cancer, are now being cured, and so it's a good time to be practicing hepatology. So to review the current treatment choices, and again, this is something that you don't have to memorize. If you're interested in treating hepatitis C, you can. There's also guidelines on the internet, and but it's something that you should just know that available many of these regimens, and really if a regimen is going to be FDA approved, then it has to be at least 92, 94% cure rates, or else it's not even going to make it to market. And there's really not anything else out, because how do you beat 99%? So I think most of the drugs are out there, and then we'll, with real world experience, we'll sort of gain post-marketing evaluation. But for genotype 1, which is the most common, you have multiple choices. So you've got 6 different regimens you can choose from. One pill once a day. One pill once a day. Here, there's a possible 8-week option where it can be treated for 8 weeks. This is 12 weeks of one pill once a day. This one probably won't be used as much because it's got more drug interactions. This one is likely out of favor as well because it's 2 different drug companies, so it's double the cost and you don't gain anything over the others. This one is can be up to 16 weeks of treatment, but it's also nice because this one can be used in patients with dialysis or who have a GFR less than 30. So that's a nice niche here. And this is a brand new agent that is 3 pills, 1 time a day though, once a day dosing, and it also can be used in patients with dialysis. So there's many good options for genotype 1. Genotype 2, you really just have these 2 options. This does have an 8-week option. So you might treat 8 weeks here, this is 12 weeks. So a difference of a month. Genotype 3, you have 3 options. Again, this one probably won't be used much anymore, so it's really the same as genotype 2 options. Genotype 4, which you won't see many cases of, you have a few options as well. And genotype 5 and 6, which are very rare, you have more than 1 option. And all of these are once a day dosing. So it's that simple. If you identify someone with genotype 6, you give them a medication for 8 to 12 weeks and they're cured. Now, I'd say it's super easy, but of course, like patients without cirrhosis who have never been treated, super easy. 1 pill, 8 weeks, done. If they have cirrhosis, if they've been treated before, those are the ones where you might say, oh, if I'm not familiar, let me just call to make sure I choose the right duration. So, or if they have cirrhosis or some other complication. But it's really going to become much more streamlined, and that's why I say I think we're getting close to even primary care being able to do this. And then there is a salvage regimen. So if you've even been on any of these agents, you can then be, and it didn't work, which again, 99% of the time it works. So the 1% of people that might be walking around, there's a salvage regimen. So not all is lost on them. And this is for a salvage regimen, this is 97% cure rate as well. And those are really difficult to treat patients. So maybe in the United States, there's going to be a handful of people, if everyone was compliant, everyone took everything, that might circle up to the NIH and we'll have to come up with something else. But everyone else is curable. Now, you learn a lot from drug trials, of course, but as you know, clinical trials are perfectly cherry-picked patients, oftentimes Caucasian predominant. And so you learn more in the real-world experience, and there's a ton of data coming out of the real-world experience, but also post-marketing safety issues. Because it's awesome to talk about curing everyone, but what are the safety concerns? We certainly don't want to take a baby boomer who is fine, and then they're dead, because we got all excited about hepatitis C. One thing that came out was significant bradycardia, and there was a couple of deaths if patients were on amiodarone. And I would extrapolate that to say any antiarrhythmic, especially if they were on beta blockers. So there are some potential interactions there that I guess can slow the heart more. Dr. Williams probably knows more about all these than I do. But anyone on amiodarone, I have treated patients on it, but it was recommended to admit them to the hospital for 48 hours to observe their heart rate while they start treatment. Because usually it would occur very quickly after the administration of the drug. But if they don't need to be treated and you don't want to take the risk, that's important. Decompensated cirrhosis. So if someone is Child's Class B or C, especially when they were taking the 2D or the 3D regimen, there were reports of significant liver injury, liver transplant, and even death. So patients that are really sick, you want to think about first, are they a transplant candidate? And that's why I had the case in the beginning of the talk about that. And many of these drugs are not FDA approved for Child's Class B or C. Most of the time when you see the cirrhosis in the clinical trials, it's well compensated Child's Class A. And then hepatitis B reactivation has been noticed in post-marketing, so that's why it's important to also check for any exposure to that. Even if someone has a surface antibody, there's a potential risk. So what do we do when we treat hepatitis C? We also check the hepatitis B during treatment and after. And if we ever see the surface antigen become positive, we can jump on that and suppress that so they don't get sick from that as well. It's kind of a strange way to think about it, but it's the way that I look at it, and I just probably don't eloquently describe it, is hepatitis B might just be archived a little bit, so it's there, but it's been dominated by hepatitis C. And the minute you eradicate hepatitis C, there's this vacuum effect, and now hepatitis B wakes up. So that's kind of the way that I think about it. Now, this, I put a question mark under, is this special populations? Because I'll tell you, we've come so far, this has happened so quickly, and the drugs are so well tolerated. By the way, the side effects on many of these regimens is 0. Okay, fatigue maybe for 2 to 3 days. Maybe a headache for a couple of days. The newer regimens that have 3 drugs in them, or if they have a protease inhibitor, a little more GI upset. Loose stools, maybe almost nobody stops treatment. Number one, they're super excited because by the time they have fatigue, they only have like 8 more weeks left, and you already tell them their viral load's undetectable. So they're like, thumbs up, no problem, I can handle fatigue. And they're super excited to be cured. But really, tolerance does not seem to be an issue to these drugs as well. But the special populations, pediatric, well, there is a drug now that was shown to be safe in pediatrics. Ledipasvir and sofosbuvir can be used, FDA approved. Elderly is not a special population. You can treat 90-year-olds with any of these regimens. Renal patients, I pointed out there's 2 regimens that can be used in dialysis in patients with GFRs less than 30. Decompensated cirrhosis is a concern. So Child's Class B or C probably needs to be managed at a transplant center. Post-transplant patients is no longer a special population. Their cure rate is just as high as someone without cirrhosis, because if you think about it, they actually have a new liver. So once they have their new liver and they're stable, we treat everyone post-transplant. And that has changed liver transplant outcomes tremendously, because recurrent hepatitis C post-transplant killed many people before these drugs came out. It's why hepatitis C traditionally had a 10% lower survival at 3 years than any other disease, but that's changed now. Patients on PPI or antacid therapy, there are several of those regimens I showed you that you have to be careful with high-dose PPI. The ledipasvir and the velpatasvir regimens specifically, if you have a high gastric pH, you'll get lower drug levels, so that might lead to you not being cured. And so PPI therapy is something that's important to look at on the med list. Patients who develop resistance, I already told you there's a salvage regimen, so this is likely, and it's really not recommended to check for resistance before you treat patients de novo. Some doctors still do it, but it's not necessarily recommended. Patients who have a TIPS or who have cancer, I put question marks because we do think that at least our own internal data has suggested that people that have active cancer have a lower cure rate, and I think it might be because blood is shunting away from certain hepatocytes that might be embedded in the cancer. And so even a few hepatocytes escape the drug, and then it can recur, and that's why I put TIPS, because the TIPS is a shunt as well. So you got to make sure drug can get to all the liver. Patients on methadone is not a problem. HIV co-infection is not a problem. There's just a few antiretroviral agents that can't be used with each drug regimen, and there's also websites you can look at. And ID doctors can switch if you need them to, oftentimes. And then the amiodarone we talked about. So drug interactions are important, and it's something that if you are going to get into treating these patients, there's not many, but a lot of your typical, sort of inducers, cytochrome P450 inducers like rifampin, the anti-seizure medicines, carbamazepine, and also I mentioned St. John's wort. Those are things that always come up in all of these drugs. The other thing is statins. Some are okay with statins. Some you can't use Crestor at all or rosuvastatin. Some you have to minimize the dose because there's an increased risk of rhabdomyolysis. But for the most part, you need to be familiar with that. The pharmacists need to kind of make sure that we're not causing any drug interactions. And there are a couple that you got to be careful with women of childbearing age because they can affect the oral contraceptives. So who would you not treat? Because I'm coming in here telling you we can eradicate this disease. If we can find everyone, we can cure them. But who would we not treat? Right now, it doesn't make sense to treat someone whose life expectancy is less than a year. So if someone walks in with metastatic lung cancer, I'll be honest, what benefit are they deriving? Sadly, but I put less than a year. So some people might have cancer that they might live 3 years with, and you could argue that if you're going to improve their quality of life and allow them to tolerate more chemo. Because sometimes cancer doctors are scared to give more chemo if there's active Hep C. Then you can probably work together on that. Again, you wouldn't ever think of that with interferon, but with one pill once a day with no side effects, it's definitely a conversation. Patients with a real high MELD score or greatly decompensated, we're not going to treat right now. We'll probably transplant them. I point this out just to tell you some of the controversies in our field. So if you're on a liver transplant waiting list, so you're already on the list at Emory, and you have a fairly high MELD score. So the average MELD score where we call people in for a transplant is 28. That's risen over the last 5-6 years. It used to be 22 when I first started. Let's say someone's got a 23. So they're not quite up at the average. They've been on the list for 2 years. And now I say, great, let's treat your Hep C. It's been shown that MELD score will drop 3 to 4 points. So now I just dropped them to a 19. Now they're almost never going to get called. Meanwhile, their quality of life sucks. They have ascites. They really want a liver transplant. They need one. So we call that MELD purgatory. Did we just put them into MELD purgatory? And now some people would argue there's not enough organs in this country. So treat everyone and let the chips fall. And if someone is dying and their MELD score is 30, they'll get one. Others would say, you know, if you're the doctor and you take care of that patient, I want to do what's best for you. And so I think that's a sort of a dilemma that we have frequently. Now, people on a kidney transplant list. So now that we have drugs that can be used on dialysis, when the drugs first came out that were safe with dialysis, I thought there was going to be just this rush of kidney transplant patients at Emory. So the first few that I saw, I walked in there, I said, you know what, we can now cure your hepatitis C, and they kind of looked at me somewhat excited about that because they didn't have cirrhosis, but they always knew they had Hep C. And then the kidney transplant doctor pulled me outside and educated me that if they continue to have hepatitis C, they will get a kidney transplant at least approximately a year sooner because they can get a hepatitis C positive kidney. Now, you all know being on dialysis an extra year has its own risks. So it's actually most patients say, don't treat it yet, let's wait till I get the kidney, treat me after. And that's what we've been doing. Now, if we knew it was going to be 10 years and they were going to develop cirrhosis, that's different. But dialysis sucks so bad, and getting a kidney transplant is so important that we're waiting. So it wasn't quite the boon I thought it would be. And then I would not treat non-adherent patients. So I put that in there because I didn't say if you're drinking or if you're smoking or if you're doing drugs. There are people that have those vices that are also motivated to get rid of Hep C. And you are going to help them, right? If someone still is going to drink 3 beers a day and they have Hep C, if you can get rid of the Hep C, you still have helped them. You still want them to quit drinking. But kind of holding it over their head, like, oh, we're not going to treat you till you quit, is also kind of counterintuitive to promoting health. But if they're drinking to the point where they're seriously not going to take their meds or they're doing drugs and they're not going to show up for weeks, that's different. But there are people that have these abuse or addictions that are still going to be compliant. And then I think if you had really significant drug interaction concerns, you want to hold. And again, maybe amiodarone is one of them. You certainly don't want people dying from the drugs. So there's been a lot of press about the costs. The good news is because there's more and more drugs that have finally, there's more than one, there's a bunch out there, it's driven the cost down a good bit. I think the whole $1,000 a pill thing is also a little bit more for the press because behind the scene rebates and what insurance companies actually pay is very much reduced. And so there's no pill that's $1,000 now. They're not cheap. I think most treatments for the 12 weeks, you're still probably looking at $40,000 or so for 12 weeks of treatment. But competition has helped reduce that. But I will tell you this, being a hepatologist, so I showed you all those graphs of peaking cirrhosis, peaking cancer. A liver transplant operation alone, just the operation, is $180,000. I'm not talking about the hospitalization, the variceal bleeding, the transfusions, so you put it all together. If you can cure people and avoid that, it's well worth it. And it definitely will save money in the long run. So final thoughts, can we eradicate this disease? It is possible. I mean, we've got a pretty easy cure that is tolerable. But what's setting us back is the new infections. So this opioid epidemic, the IV drugs, this is setting us back. And of course, worldwide, right? How do we get these drugs and how do we screen people not only in the United States, but worldwide? Vaccine, there was a lot of research on vaccines. It may not be needed anymore. I think a lot of that research is kind of stalled. I mean, you may still learn other scientific principles from this, but it was very tough to have a vaccine for this virus. Can we expand the organ donor pool? So just to give you an example, We are currently, and other centers are already doing this, so we're not the first, but everyone at Emory is on board with, obviously with consent, giving patients an organ that has hepatitis C risk, and the patient themselves does not have hepatitis C. So we're going to give you this liver, and we're giving you hepatitis C basically, but we're going to save your life with a new liver, and we'll give you a pill for 8 weeks, and you'll never have a problem. So if they sign consent, it expands the donor pool, and quite frankly, a lot of these organs that you get are young people that unfortunately were doing drugs, but they're young, so their liver is very healthy. 21-year-old healthy liver going into someone that's sitting in an ICU begging for a donor to come along. Yeah, I'll take hepatitis C, just cure me 8 weeks later. Dr. Spivey was actually in a committee conference where he said, I'd take HIV. He's like, if I'm dying, give me an organ with HIV. We haven't gotten there yet, because that's obviously a long-term treatment. But hepatitis C, it's very conceivable. We already give people organs that have a risk of hepatitis B. So we already have a precedent for that. And I'll be honest, that's probably more expensive because you put patients then on entecavir or tenofovir forever, not just 8 weeks. So it's interesting if you don't think of it that way. But that may expand the donor pool some. And then how do we follow up with patients who have been cured? This is so important. We got to make sure that they're not going to just disappear and come back with liver cancer. We think we can reverse cirrhosis in some cases, but how we monitor that is unclear. And then what's the risk of liver cancer I talked about. And then I put this at the end because this is what we all can do. When you walk out of here today, the next patient you see that has risk factors or is a baby boomer, help us find the people that are out there that don't know, and then let's just cure them and put that behind them. So thanks for your attention, and I hope that was helpful.
Sure. That patient.
Yeah, so that certainly could happen with injection drug users.
Right.
So you can retreat them. So often it may even be a different phenotype sometimes. In fact, that has come up in a few cases where I talk about 99% cure rates, where someone would come back with viremia, and you're like, oh, but they were cured, but when you checked, it was a different genotype. So it was actually a new infection, not a relapse of the old. I think we will see that. Technically, unless it's a superbug with a lot of different mutations, it should still be just as easily treated. I think what the problem is going to be is insurance. I mean, when is Blue Cross Blue Shield going to say, hey, I've already treated this guy once, I'm not going to just keep doing it. But when they first came out with recommendations to treat active IV drug users, you can see there was some debate there. In fact, I was up in New York at a conference, and I kind of protested a little bit to that concept, just saying, that was when it was really hard to get drugs, and I just thought, well, maybe this is a little bit reckless. And I'll tell you, I got like booed out of the. I should have realized I was in New York, honestly. It's just like they're always going to be thinking like that. Whereas in the South, there were plenty of doctors that are like, man, if you're treating people using drugs, I'm out of here. So we just have to kind of be careful. There are some, but what the stance that they take, and they have all these different diagrams, is they'll show by treating active users, you're reducing downstream a bunch of new infections, and they have these numbers, and so that's kind of their rationale.
So you don't think a reinfection makes it harder to treat?
Shouldn't, yeah. So far, the hardest to treat, people who really are hard, are just advanced cirrhotics who've been on multiple treatments, so it's not so much the new infections. And if someone does get acute hepatitis, it's kind of hard to start treatment immediately, because sometimes they do just get rid of it on their own. But it also, like if there was a needle stick, most algorithms are probably going to say, here, just take this pill, to make sure it never becomes a problem, because side effects are easy. And what I do on these talks, and I hope it's helpful, I've been to just so many talks, and this is true of any field, pulmonary, cardiology, and it's not that the specific studies aren't important, but to come up here and to show you 120 different studies, you walk out of here and your head's spinning. Even for me, and that's what I do. What's nice about this is I can truly summarize it that all of those drugs are 96% or better. So they're all good. And there's going to be, and I always tell people, you'll see drug companies come by, they're all good. What do you want? And like if an insurance company says, well, we're only going to use the drug, use it. It works. Just be careful with the side effects and the drug interactions.
So it's